What's up, you guys? Welcome back to From the Ground Up. Today, we're going to talk about something that I personally see all the time in my clinic. And it's one of those things that you guys are seeing too, and that we've been taught, and that I want to kind of push back on a little bit today. It's something that sounds right because, again, this is kind of how we've been taught, but it's actually maybe one of the things that's keeping your patients stuck and even driving their symptoms. What I want to discuss is this idea of belly breathing versus diaphragmatic breathing versus 360 breathing, all the breathings, and why it really does matter clinically, okay? So I'm just going to come out and say it. Belly breathing is not the same thing as what we'll say diaphragmatic breathing, okay? Now, caveat, every inhale or exhale we take, the diaphragm is being used. So technically every type of breathing is diaphragmatic breathing. But in the traditional sense, there's a difference of just belly breathing or fully utilizing the diaphragm, okay? But so many of us are taught to cue breathing into the belly, expand the belly. And, we're even taught to give tactile cues on the belly to our patients to cue them to kind of expand and breathe there, okay? But I'm telling you, if your patient is only or primarily breathing into their belly, they are likely reinforcing the exact pressure strategy that is driving their symptoms. Belly breathing isn't optimal diaphragmatic breathing, you guys. And if we do not ensure that the rib cage is what's primarily moving when our patients are breathing, we are going to be reinforcing the exact pressure strategies that it's driving their dysfunction in the first place. So I want to break it down simply today and kind of give you some clinical things to be thinking about so you can actually go and try this tomorrow with your patients. Yesterday, I had a patient in here. She is 30 weeks pregnant, and she came because she was having just sudden and severe debilitating SI joint pain. Like I saw her walking in and it was like, it's her left side, and it's like, she can't quite weight bear on that left. She can't accept load over there. She's kind of doing the lateral lean thing, and, rolling in bed hurts. It's all the things, all the pregnant pelvic girl things. And it was just so sad. So all that being said, I was, doing her eval. I was assessing her. I had her up on the table. She was in supine hook lying. And, I just was kind of observing her breathing, her breath pattern. And I said, okay, go ahead and just like take a moderate breath for me. And, what I saw was literally 100% belly expansion. And when I tell you her rib cage was a brick, like it was a block of cement, you guys, like it did not move. And her belly, I know it was already, she's 30 weeks pregnant, so it's already a little bit expanded, but with her breath, like it blew up like a balloon. Okay. And I was like, in my head, I'm like, dang, her rib cage isn't even invited to the breathing party at all. And, I told her, we got to talking about it, and she was kind of explaining, interestingly, this is how I've been taught to breathe. Like she's been in choir, she's played sports, and all her life she was like, this is where people have cued me to breathe. I thought I was breathing correctly by expanding into my belly, breathing into my belly. That's what they do in yoga, all the things. She thought she was doing it right. And so she had formed this habit of belly breathing. Okay. This is what most of our patients believe also, especially if they've been to PT or, tried to do some self-research or whatever, is the belly breathing thing. But honestly, truthfully, this is what we have been taught too as clinicians. And I'll say it again, this is what's further driving patients' pressure symptoms, is this idea of just belly breathing and not really utilizing the entirety of the rib cage so the diaphragm can function optimally. So let's talk about what is belly breathing actually doing. So like I said, every breath uses the diaphragm. Okay, this is not diaphragmatic breathing versus non-diaphragmatic breathing. That's not a thing. If your diaphragm doesn't work, you're dead. Okay, you're not breathing, you're not getting oxygen, and you're dead. Bye. What I'm talking about here is how we are breathing. It's all about where pressure is being directed. That is the difference between belly breathing and what we'll call rib cage breathing, okay? It's where the pressure is going in our body, in our system when we are breathing. So with a belly dominant breathing strategy, you can imagine a belly breather. They expand anteriorly into the belly, right? The belly blows up like a balloon. So we get this anterior abdominal expansion. That is actually going to reinforce kind of an external rotated position of the pelvis, of the iliums, which further kind of takes it into more of an anterior orientation. I'm not vilifying. I'm not vilifying. I'm not saying it's a villain. I'm not vilifying anterior pelvic tilt here. I'm just saying if someone's only belly breathing, they're only staying externally rotated and anteriorly oriented, and we don't want that. We don't want anyone stuck anywhere, right? So belly breathing kind of reinforces that anterior orientation and external rotation of the iliums. What that does is it actually creates, you can imagine if the iliums externally rotate and anteriorly orient themselves, you can imagine it creates like a compression on the posterior aspect of the pelvis. Okay, so we get this posterior compression of the pelvis. We also, because the rib cage just is not moving much at all and it's all just expanding in the belly, we get compression a lot of times of the entirety of the rib cage, but especially posteriorly in the rib cage. The thorax is compressed. The pelvic floor, the posterior aspect of the pelvic floor is short and compressed. And because of that, because the posterior pelvic floor is kind of shortened and compressed due to the bony change of the pelvis itself, now the anterior portion of the pelvic floor is overly lengthened, okay? So now instead of pressure being distributed, throughout the abdominal and thoracic cavity and being equalized throughout the cavity, instead of that happening, it's actually now being more dumped and forced forward and down onto the front of the pelvic floor. And, what did we just talk about? The anterior pelvic floor is now overly lengthened due to ilium position, right? So this pressure is now being forced down and forward onto the front of the pelvic floor that can't even do its job properly because it's overly lengthened because of the bony position of the pelvis. So it's also putting the abdominals at a disadvantage in a similar way because of them being overly lengthened with this like overexpansion due to primarily belly breathing. Okay. And like length tension principles tell us that an overly lengthened muscle cannot work properly. Neither can an overly shortened muscle, right? We want kind of the porridge just right. But this is what's happening in belly breathing is our abdominals are getting overly lengthened. So they can't do their job very well. They can't, manage pressure and keep it in very well. And then the anterior pelvic floor is getting overly lengthened and the posterior pelvic floor is getting overly shortened and just continuing to exacerbate its own problem. It's now like its own self-fulfilling prophecy cycle, right? And it's shoving all that pressure forward onto an overly lengthened pelvic floor. And that's not going to be able to keep peeing, y'all. Those muscles are overly lengthened on the front side. It's not going to clamp that urethra off. It's not going to support the bladder, right? So this is why we get those pressure symptoms. It leads to things like leaking, prolapse, heaviness, pressure, persistent pain. Okay. Because think about this, that constant compression and pressure on the back side, that causes things like SI joint pain, you guys. Like when the SI joints don't move because the iliums are just so externally rotated and they don't get a ton of motion into that internal rotation, we get compression at the SI joints and that becomes painful. Okay. And so it's just yet another example of the pelvic floor being the victim, in this case of poor breathing mechanics and pressure distribution, rather than the pelvic floor being the root cause of someone's leaking or SI joint pain. The SI joint's not the problem. It's the pelvis positioning and the breathing mechanics. So Kegels nor relaxation or stretching drills are not going to improve the pelvic floor function in this instance because the length tension relationship and the pressure where it's being, driven into, you can't overcome that with more Kegels and you can't overcome that with just relax, just breathe. You're going to make it worse because they're breathing into their belly. You're going to exacerbate, become a self-fulfilling prophecy, okay? So what do we actually want? If we don't want belly breathing, what do we want? So this is where I'm saying this is more of what I call kind of rib cage breathing. I've heard 360 breathing because of the 360 degrees of the rib cage. Whatever you want to call it, we want the rib cage moving. The goal is kind of that 360 degree pressure distribution throughout the system, throughout the rib cage. We want rib cage expansion in all directions. Yes, like we want, lateral, we want anterior and posterior, we want apical. It needs to be able to expand in all the directions, like full stop. And in a lot of our patients, especially ones that tend to be belly breathers, they really, really need kind of that lateral and like that kind of that posterior expansion of the rib cage. Okay. So, what changes then when ribs are able to move and kind of we are able to create that space within the rib cage cavity? This is when we see it decreases the pressure that is being dumped anteriorly onto the pelvic floor because the pressure now has somewhere else to go. It can distribute more evenly in the rib cage simply because the rib cage is moving more. It's expanding more. So it's going to reduce that anterior pressure dumping. It's also going to reduce that posterior kind of compression, that shortened posterior pelvic floor, simply because we know that the rib cage position drives pelvis position. So if we get more posterior expansion in the rib cage, that's automatically going to allow for more posterior expansion and ilium internal rotation in the pelvis as well. Also, improving the shape of the rib cage, the mobility of the rib cage, the expansion capabilities of the rib cage it's simply just going to improve the diaphragm's positioning and its ability to pump more effectively. Again, all breathing involves the diaphragm, so I'm not saying it's belly breathing versus diaphragm breathing and trying to say that belly breathing doesn't utilize the diaphragm, but by utilizing the rib cage and ensuring it has mobility and expansion capabilities, we're kind of creating more of a cylinder in the rib cage so that way that diaphragm can dome and flatten more appropriately and more fully. So it just makes it more effective. So posterior rib cage expansion is the thing that's really going to lead to that posterior pelvic floor expansion. And that is what's going to optimize that length tension relationship of the entire pelvic floor. Because, if we're taking the pelvis from compression of the posterior aspect and overly lengthened in the anterior aspect because of those iliums being externally rotated, now we create this expansion. Iliums can find a little more internal rotation that expands that posterior pelvic floor better. It's going to allow more compression on the anterior pelvic floor, more natural, normal amounts of compression. And just by kind of restoring that anterior and posterior length tension relationship at the pelvic floor muscles, it gives the pelvic floor a much better opportunity and chance and environment to be able to function simply because of length tension principles. So when we're thinking of this, how are we actually helping our patients get out of the belly and move their rib cage? And I want to talk about what I do clinically, because this patient that I mentioned yesterday who I saw and who just was like 100% belly, 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 she struggled whenever I tried to give her just a verbal cue of like, oh, okay, so I'm seeing a lot of belly expansion on your next breath. See if you can direct the inhale a little bit more into the rib cage. And, she didn't have any idea what the heck I was talking about. And that's okay. So what I tend to do when someone is kind of struggling to make that connection with mobility at the rib cage is I actually just like to place my hands on kind of the lateral aspect of their rib cage on both sides. And sometimes all they need is the touch. And, that kind of gives them that tactile cue, that tactile awareness of, oh, okay, so that's where she wants expansion. Well, for my patient yesterday, that didn't do it. Like I'm telling y'all, her ribs were like locked the heck down. They did not want to move. And so I had to actually put a good amount of pressure and force into that rib cage just so she could feel and sense and have that awareness of, okay, her hands are compressing here, which it was already pretty compressed. So I had to give it a good oomph for her brain to really notice that it was compression, right? So her brain is now able to say, okay, so I feel compression there. And she's saying to expand into that compression. Okay. So it kind of gives her just that tactile feedback and being able to expand into my hands. And with that added pressure, she did really, really good. Now, I could tell it was pretty forced on those first couple breaths. So, sometimes people, when they first find this ribcage mobility, it's almost like they're having to like push the air there. They like, instead of it just going there, they have to like really concentrate, and physically it's like they really are trying to push the air there. And, the abdominals engage a little bit more, because the brain is saying, okay, she doesn't want belly. So then they kind of get a little bit more concentric in the abdominals to not allow the expansion there. And it just feels like really physically forced. So a really great cue that worked for her, and it works for a lot of my patients, is once they get that, once they, if they require that good amount of pressure on their rib cage, and if that helps them kind of find that expansion, and I'm noticing it's a little bit more forced, a great cue is super simple, but don't overlook it because it really works. I just simply say, okay, great. Now, can you just see if you can allow your breath to go into that pressure that you feel from my hands? And I might say like, don't feel like you have to force it. Just see if whenever you breathe in, if you can just allow it to move there. And that one, it clicked. And suddenly, her belly softened a little bit and her ribs became a little bit more buttery, if you will, a lot more mobile. And had she needed this cue, I would have given it. Sometimes I'll say, just keep your belly soft and just allow the breath to go into that pressure that you feel. She didn't quite need that, but sometimes I do have to say that. So letting your breath go where the pressure is, keep your belly soft, but that's a little bit, I don't really give that belly cue, that soft belly cue until they found their rib cage. Because first of all, their belly's been pretty soft to do belly breathing, right? It's really only once they found that rib cage and they're forcing it. And so those abdominals have become a little bit more concentric. So keep your belly soft. And then sometimes I'll see that they'll kind of try and suck in. They're like, okay, I'm sucking in to really expand that rib cage. And so just making sure they're not sucking in. The belly, we will see some belly expansion here. I'm not saying the belly is not going to move at all, right? But ideally, we're not seeing the belly expand until the end of the inhalation. Like the rib cage is the first and the primary expander. And then as they draw in a little bit more air, then it starts to go into the belly. So what I want you to take away is literally, if the patient's rib cage doesn't move, the pressure has nowhere to go except down. And when it's super locked down and it's belly breathing specifically, that puts that pelvis in that externally rotated position with a little more anterior orientation, which means that we have posterior pelvic floor kind of compression, and then anterior pelvic floor, it's a little bit more lengthened. It's overly lengthened. So there's a mismatch of that length tension relationship on both the anterior and the posterior, and it can't do its job. And so when the rib cage isn't moving and we're doing primarily belly breathing, that pressure is just going down and forward and out. And that anterior pelvic floor that's so overly lengthened, it can't keep it in. So no wonder people are peeing their pants, okay? And they're having prolapse. If your patient is only breathing into their belly, they are likely reinforcing the exact pressure strategy that is driving their symptoms in the first place. Belly breathing is not optimal diaphragmatic breathing, you guys. And if we don't ensure that we restore rib cage expansion throughout the entire rib cage, yes, but probably especially posteriorly, we are probably reinforcing the exact pressure strategy that's driving their dysfunction in the first place. Okay, so let's stop cueing belly breathing and let's start looking at the rib cage and making sure it can move, people. It can expand, and you will be shocked at how much better your people do, and they stop peeing their pants and they stop having prolapse and all the things. So hopefully this was helpful. If it was, I would love to see you share this episode to your stories and tag me. I always love seeing you guys listening to the show. I always love DMs about it. What did you love? What did you hate? Okay, maybe not what you hate. Just kidding. I can take it. But let me know. I just want to know what you guys are thinking. If you have questions, I love answering those in the DMs. But yeah, this is how we change the game, you guys, by being better together. So share this with others, other pelvic floor PTs, OTs, coaches, anyone that you know that you think it would be helpful. Hope you have a great rest of your day, y'all. Let's change the game.